Good evening, esteemed faculty members and all the delegates. Thank you for joining. This is Sahiti on behalf of Shield Connect. Welcome you all for today's webinar, Blossom webinar. So it's my privilege to introduce the MOC of today's webinar, Dr. P. Radhika Gauri ma'am. Ma'am is specialist consultant in OBG and clinical lead at ESIC Hospital, Tirunelveli. I welcome you, ma'am, and I hand over the session to you.
Thank you, Saiti. Good evening, esteemed faculties. I welcome you all for the yet another session. Now, I'd like to introduce Dr. Kalpana ma'am. Dr. Kalpana ma'am is the chairperson of Infertility Committee, and she's also joint academic secretary of TAPISAR, and she's the founder secretary, Madurai chapter of TAPISAR since 2020, and she's the co-chairperson of Infertility Committee, TNFOG, and she's also the past vice president of MOGS, organizing secretary of MOGS Silver Jubilee Conference in 2018. And also she organized MOGS annual conference in 2023 during the South Zone VP conference 2023 and mid-year conference TAPISAR in 2026. So she is a member of institutional ethics and principal investigator in clinical trials. And she's the course director for postdoctoral fellowship in endogynecology affiliated to MGR Medical University. She has won numerous awards. The first is the Best Doctor Award by MGR Medical University and Golden Excellence International Award by European Continental University. Medical Excellence Award in 2018 from the Governor of Tamil Nadu. Best Medical Service Award from Madurai District Collector. Best Committee TNFOG Award from Health Minister in 2022. Turner Anemia Foxy Achiever Award in 2023. Foxy Badlav Appreciation Award in 2023. ISR Rising Star Award 2023 and received Legend of Gynecology Award from the Foxy President. And she received Foxy UNICEF Appreciation Award. So many awards, and I welcome her to give the welcome address in this session. Welcome, Kalpana ma'am.
Yeah, thank you, dear Radhika, for starting the program. Actually, it is my honor to welcome you all for this Blossom webinar series, which had been very successful over the past few months. Which is actually every webinar I tell about the meaning of blossom, which represents flowering part of a plant which forms fruit. So this is a webinar on reproductive medicine. So in this webinar, we have our chief guest, Dr. Lakshmi Srikatte ma'am, who is known to everyone, who has been associated with Tamil Nadu in various webinars and immediate past ICOG chairman, and also she's representing India Foxy in international platforms also. We also have our dynamic secretary general of TNFOG, past vice president Sampath Kumari ma'am, as our guest of honor, who has been running across India to reach her goal in the immediate future. Really few days left to reach her goal. Wishing her best luck, and would like to see you in the highest possible position of Foxy. And also we have interesting topics, panel discussion. One is unexplained infertility. Many a times, majority of infertility is unexplained. Many a times, if we encounter failure also, it is really difficult to explain the reason for failure. So this interesting topic is going to be discussed by Suparna Banerjee, my dear friend. And we have also wonderful panelists, Dr. Archana, Dr. Pradibha Singh, Akansha, Dr. Shamili, Dr. Rohini, Dr. Anuradha, Dr. Piyusha, Dr. Prachi. They are going to discuss about unexplained infertility in detail, and also we have interesting topics. It is not only patient factor and clinician factor, embryology and lab factor play an important role in coming to a success. IVF lab, uncensored evidence, errors, and everyday decision. That is going to be discussed by Suvarchala, who has been associated with our webinars in the past webinars also. So she will be moderating the panel, and we have experts, Dr. Devan, Dr. Sashi Kumar, Dr. Dania, Dr. Fairy, Dr. Praveen, Dr. Suhashini. They are going to contribute their experience and literature evidence in this panel discussion. So with this interesting topics, I hope delegates will be really benefited out of this. Thank you so much. Over to you, Radhika.
Thank you, Kalpana ma'am. That was a wonderful introduction. Lamp lighting to invoke the blessings of God. Now, I invite Dr. Kalpana ma'am to introduce Dr. Lakshmi Shrikande ma'am, our chief guest.
Yeah, it is my honor to invite and introduce Lakshmi Shrikante ma'am, who is known to Tamil Nadu because she has been visiting offline and online to webinar in various webinars and conferences too. She's presently holding the prestigious post of FOGSI representative to AWOFOG, and she is into various other international platform also, member of SAFOG Educational Committee and FIGO committee member for climate change and toxic environmental exposure. She is the past immediate chairperson of ICOG and national corresponding editor of JOGI. And she is into various association, ISOPA and Indian Menopausal Society and whatnot. She was a chairperson of HIV/AIDS committee previously in 2007 to 9 and president of NACPU. She's a medical director and senior consultant in Shrikante Hospital, Nagpur. And she's received various prestigious awards, including honorary FRCOG and Nagpur Ratan Award from Honorable Union Minister, Bharat Excellence Award from for Women's Health, and appreciation letter from Maharashtra government too. Delivered various orations and publications, almost 62 national and 31 international. Welcome, ma'am, for your words of wisdom.
Thank you. Thank you so much, Kalpana, for those nice words. And good evening, friends. It's my privilege to be chief guest for today's Blossom webinar. And I'm so happy to share this with my dear friend, Sampath Kumari. I wish her all the very best for her election campaign. I extend my heartfelt congratulations to Dr. Kalpana for conceptualizing and organizing this wonderful academic program. I know Kalpana since so many years, and I must say that she's a dynamic leader, an outstanding academician. Currently, she is the chairperson of FOGSI Infertility Committee, where she is doing wonderful work. She is a passionate teacher who has consistently worked to enhance fertility care and education across the country. Kalpana, your dedication to bringing meaningful and practical learning opportunities to clinicians is truly commendable. I would also like to acknowledge and appreciate Dr. Shanta Devi, who is the Secretary of MCOT, for her constant support and efforts in making this webinar possible. Academic excellence is always the result of teamwork, and today's event reflects the commitment of the entire organizing committee. Kalpana, your topics selected for today's webinar are highly relevant to daily infertility practice. Your first session on unexplained infertility will definitely help clinicians navigate one of the most challenging situations in reproductive medicine, where diagnosis is uncertain, but individualized management is crucial. Your panel discussion will undoubtedly provide practical insights and evidence-based solutions. Your second session is also you have thought of very well. That is IVF lab uncensored evidence, errors, and everyday decisions. This is equally very important. We all know that success in ART depends not only on clinical expertise, but also on the quality and precision of laboratory practice, and embryologists, they play a great role in our IVF success rate. So understanding the science, avoiding common pitfalls, and making informed decisions will definitely improve the clinical pregnancy rate for our patients. I also would like to congratulate the moderators, speakers, panelists, and participants who have joined today. Continuous learning and sharing of experiences are essential for advancing fertility care and improving patient outcomes. I am confident that this webinar will stimulate meaningful discussions. It will enhance knowledge and provide practical take-home messages for everyone. My best wishes again to Kalpana, Dr. Shanta Devi, and the entire organizing team for a successful program. Thank you for having me here, and I wish you all happy learning.
Thank you so much, ma'am, for your blessings. Our secretary, Shanta Devi, is stuck in an emergency. She'll be joining soon. You're muted, Radhika.
I request Dr. Kalpana ma'am to introduce Sampath ma'am. Ma'am, Shanta Devi ma'am is busy. I mean, she's on the way.
Okay, Sampath madam, see. Sahiti, can you please change
Sahiti?
the CB deck? Can you please? So it is my honor to invite and introduce Sampath Kumari ma'am, who doesn't need any introduction actually, who is the dynamic Secretary General of TNF Fuji, past Vice President of FOGSI in 2022. She is also Senate member of MGR Medical University, National Corresponding Editor of Doggy. And she's President Board of Studies, Dr. MGR Medical University. She has started her FOGSI career as Adolescent Committee Chairperson in 16. So almost for more than a decade, she has been working for FOGSI, and first ICOG Distinguished GC Member Award in 2021. She's also into IMA Chennai South, Chairperson of Women's Wing. IMA National President Award also she has received. This CV is very short, but her credentials are too long to explain in this webinar. And the thing is, she is taking a challenging task in this year. In almost another 40 days, August 1st, her campaign ends and she is contesting for president of FOGSI. In this year 2026, she has been working hard over the past few years. Wishing her a great luck. And also, Sampath madam, can you please give your blessings and words of wisdom for this webinar?
Thank you, Kalpana, for the nice words. See, we know about Dr. Kalpana, always silent worker. And she's doing this, I think, for more than 3 or 4 months, this blossom. Now it had blossomed, I think, fully different topics and wonderful webinar. And I am happy to share this session with Dr. Lakshmi Srikande. She was the Foxy representative to AOFOG, and she is a past Nagpur president also. And our secretary, Dr. Shanta Devi, she has held up in some cases. Dr. Kalpana always makes the topics different. This unexplained infertility, as per records, it is 30% unexplained infertility. But I think the incidence is still, it is increasing. Or everything will be normal, but still they may not be able to conceive. So this is the case now. For this, we have Dr. Suprana as the moderator and the wonderful panelists Archana, Pratibha, Akansha, Sharmaste, Rohini, Anuradha, Piyusha, and Prachi. I think everyone can have a good take-home messages and to tackle the unexplained infertility. And even the general gynecologist can get some few tips from this, I think. And the next topic, as Lakshmi Madam was telling, IVF lab, uncensored evidence, errors, and everyday decisions by Swachala, moderator, and panelists being the Devan Patel, Sasikumar, Danya, and Fari, Priyank, Praveen, and Suhasini. So these two topics every Wednesday, I think. Now all people will be very in a mind that every Wednesday 6 o'clock we should be in the webinar. Now the new entry is Dr. Radhika. Radhika, welcome. And thanks to Kalpana for this wonderful webinar and the faculties and the delegates for attending this webinar. You attend in a large number and you can have a good take-home messages. And humbly, I am requesting all of you, I am contesting for Foxy President. The election time is August 1 to 10. All of you, whether north, east, west, or south, please vote for me. Vote only for me. Thank you. So August 1 to 10. And once again, I thank Kalpana and Shanta Devi for this wonderful opportunity. Thank you, Kalpana, and I wish all the best for the success of this webinar. Thank you, Kalpana.
Thank you, ma'am.
Thank you so much, ma'am, for your blessings. And from our team, we wish you good luck in the immediate future endeavor and wish to see you as Foxy President.
Yes, ma'am. Thank you, ma'am. We will move on to the first session. The first session moderator is Dr. Suparna Banerjee. I invite her. Now, she's the Secretary of ISAR Bengal 2024-2026. She's also Secretary of Scientific Committee of UASR 2021 and Assistant Secretary of Scientific Committee of ASCOG 2023. And she was the Secretary of Subfertility and Reproductive Endocrinology Committee of BOGS 2022 and 2025. She has been trained in assisted reproduction from Peninsular Center for Reproductive Medicine in UK. And she is the medical director of Ankur Fertility Clinic and IRS in Hooghly. And she's an orator in national and international conferences, author in international journals and book. And she's the secretary of IFS Bengal chapter between 2018 to 2020. I invite you, ma'am. And I request you to introduce the panelists. Dr. Suparna, ma'am. Sahiti.
I saw her name.
Can you hear me?
Yes, ma'am.
Okay, let me introduce my panelist, Dr. Archana Kanodia. She has got special awards and achievements and executive ex-member of UP Medical Council Global Excellence Award for the Most Trusted IVF Center and Pradhan Mantri Surakshit Matritva Abhiyan. Next slide, please. Dr. Pratibha Singh. Yes, she is presently senior consultant and laparoscopic surgeon, and writing is so small I cannot see properly. It's very small.
From the
Radhika, ma'am, or
yes, ma'am.
can you introduce, ma'am?
Yes, ma'am, sure. She is from the Tender Palm Super Specialty Hospital in Lucknow. Her special interests are high-risk pregnancy, infertility, laparoscopy, and robotic surgery. And she has experience of more than 15 years from premier institutes in Lucknow and RMC, KMC, Bangalore. And she's done advanced training in infertility, Delhi, Mumbai, Ahmedabad, and laparoscopy and cosmetic gynecology. She has won excellence awards in 2023, and she has credit of first female robotic surgeon in Uttar Pradesh. She's presented and published many papers and posters in various national conferences, and she is regularly conducting various health awareness programs in societies, hospitals, schools, and colleges. She's a member of FOXI, ISAR, IAGE, PICO Society of India, ISOPAR, and JMA. Welcome, Dr. Pratibha Singh. And
Dr. Akanksha Mahajan. She is the recipient of the IMA Prerna Samman for the year 2025, DNB Board Certified Tutor for Postgraduate DNB Student, ex-consultant of Craft IVF Kerala, and winner of State Level Kerala ISAR Quiz 2021, runner-up for State Level Partition Quiz of 2021. Welcome, doctor. And then Dr. Shamli. Dr. Shamli is medical director of Arogyo Women and Children Care Hospital and IVF Center. And in Shambhajinagar, Dr. Shamli is a highly experienced consultant obstetrician gynecologist and infertility specialist. She is known for her patient care approach and clinical acumen. And her areas of interest include the high-risk pregnancy, IVF, PCOS management, etc. And she is committed to provide evidence-based compassionate care to all her patients. Welcome, Dr. Shamli. And then Dr. Rahini. Dr. Rahini is she has a fellowship in reproductive medicine, advanced diploma in ART and reproductive medicine from Kiel, Germany, and senior consultant in Indira IVF Hospital in Shambhajinagar and clinical director of Indira IVF, Chhatrapati Shambhaji Nagar. Dr. Anuradha. Dr. Anuradha is diploma in assisted reproduction, University of Kiel, Germany, diploma in pelvic endoscopy, and director of Shauli Hospital and Ajanta Fertility Center, Aurangabad, participating in IVF and endoscopy for practicing for last 20 years, founder member of MSR and ISAR, Dronacharya Awardee, past president of Aurangabad Obs and Gynae Society, FOXI recognized training center for ART and infertility, ISAR embryology training. Then Dr. Piyusha. Dr. Piyusha is MS and she is a fellow of ICOG, advanced diploma training in the ART and reproductive medicine from Kiel, Germany, diploma in aesthetic gynecology, ultrasonography certification, and her area of interest is infertility and ART, high risk pregnancy, minimal access surgery, and she has got many awards, first prize in paper presentation in IAG conference and winner of ASI state level undergraduate surgery quiz and runner-up of Dr. Leela Dubey Memorial Obs and Gynae quiz. Dr. Prachi Agarwal, she has a fellowship in ART, senior consultant in Awadh Hospital, director of Shusri IVF Center, Lucknow.
so we can start the panel.
Yeah, I start my screen sharing.
Okay.
Share. I'm sharing my screen. Can you see my screen?
We can see your screen, ma'am. Can you minimize this Zoom tab and open the PPT, ma'am?
Yes, the PPT is it's
now we
open.
can see, ma'am. Yeah, please make it as full screen, ma'am.
Full screen, yes. Yes.
Thank you, ma'am. Yes, ma'am.
Can you see?
Yes, ma'am.
Okay. So we'll start from the definition. Infertility in couples with apparently normal ovarian function, fallopian tubes, uterus and cervix and pelvis, age less than 40 years with adequate coital frequency and apparently normal testicular function and genitourinary anatomy and a normal ejaculate. So this is the diagnosis or definition of the unexplained infertility. Everything what the test we do is normal, but if they are after 1 year of trying unable to conceive, then they are unexplained infertility, and with routine or standard investigation there is no abnormality detected, and this is from the RCOG guideline. So how to diagnose? Diagnosis is due to lack of specific test of misdiagnosis, or it can say misdiagnosis of test, and most frequent reason of misdiagnosis is mild endometriosis, premature ovarian failure, and mild tubal disease, immunological cause or chronic infection. Now, was the infertility, what was the, how you do the evaluation? So, whatever the test we do, are they complete, or was it performed correctly, or have we interpreted the result appropriately? So, we need to think about those things, and then we can probably diagnose the cause of unexplained infertility. So, prognosis in this group is good if they are young, so, and they are less than 35, and duration of fertility is less, that is less than 2 years. So, what is our aim here? For improving the gamete quality, increase the gamete number, and facilitate the gamete interaction. Now, coming to our first case scenario. So, Mrs. A, 32-year, married for 8 years, primary infertility for 6 years. Thyroid prolactin normal, AMH is normal 2.6, USG so showing normal antral follicle, nothing abnormality in USG. HSG tubes are patent, husband semen analysis is normal. Okay. Uterus and antral follicle is 5. Past history of ovulation induction for and timed intercourse. So we'll start from Dr. Archana. Dr. Archana.
Yes, I'm here. Yes. In this
So-
case, this is the case scenario 2. 1, please.
One. I'm going back to 1. Yes. So basically, she has got antral follicle number. You can see 4 and 5.
Yes.
And the adherent ovary.
And AMH, and what is the AMH of this patient?
AMH was 2.6.
Yes,
I'll
yes.
go to the last one. It was 2.6.
Yes. So in this case, the AMH is very good, means good respond very if we do IVF stimulation, but in this case there is a tubes, HSG tubes are patent, and
Semen analysis normal.
semen analysis normal. And second slide, but the primary fertility for 6 years. One is
She's 8 years. They're trying for 8 years, and she is 32.
yes. Second slide, please.
Second slide is her antral follicle count, which you can see it is
Yes,
moderate.
yes, antral follicular count right in 4, and left ovary adherent to uterus. This is the red flag sign. Is the left ovary is adherent
Yes.
to uterus, and in this condition there is strongly suggest toward the any adhesions or either deep pelvic endometriosis inside the pelvic cavity. So
So
we
as
can,
there is a discrepancy in follicle count and the AMH, so if
yes.
you want to go by it, so which one you will take? The AFC is you will take that is right, or the AMH is right?
I think AMH is good, and AFC, if count the AFC means 4 plus 5 means 8 follicles, 8 follicles in total calculate means it give result if we stimulate this patient.
So what do you want to do next then for her? She is now in your chamber and she already had 5-6 times ovulation induction by oral ovulations.
Yes, so my next step is to what is the reason behind the adherent left ovary adherent, why left ovary is adherent to uterus, if there is any adhesion to exclude the cause of adhesion, and second thing, if there is
How do
a
you want to do it?
I want to do laparoscopy, minimal invasive surgery. For this, we look what is the reason behind the adhesion. Either there is a means a pelvic adhesion or endometriosis, or because there is when there is a adhesion, there is a oocyte pickup during oocyte pickup impaired, and so maybe if one tube is patent and another is closed, there is an inability of means sperm oocyte fertilization is poor in this condition, I think. So I think we go towards IVF.
IVF you are going to, but laparoscopy you want to do before that.
Yes.
So anybody in my panel beg to differ? Dr. Pratibha? Dr. Pratibha, are you there?
First,
Yeah.
we go towards IVF first and then do minimal invasive surgery, because if we do first laparoscopy, it will decrease the value of AMH or AFC count. So I think first we go towards IVF, and
So
after
you counsel the patient for IVF.
yes, yes.
Okay, Dr. Akanksha, do you want to do IUI for this patient?
Yes, ma'am, I beg to differ, and I will advise her IUI as next step because she has now undergone ovulation induction for 6 times. So, as per guidelines, next appropriate step for her is going to be super ovulation and IUI. And if at all the follicle forms on right side, and because right side is freely, right side ovary is free, although left side is adherent, then she has good chances to conceive in IUI also.
Yes, that is another option. Yes, IUI we can offer, but we need to counsel her that the success rate she has to think about. For her success rate will not be more than probably 10% per attempt of IUI. So her expectation should be. Yes, ma'am.
She had played 5 to 6 cycle ovulation induction.
Yes, she already had 5 to 6 times ovulation induction. So you can do gonadotropin stimulation for the IUI, that will increase her chance. And in that case, probably one IUI can either give you result that is very good. Luckily, if not, then we will get some more information about the follicular development. And when you are using gonadotropin for IUI stimulation, it is kind of a mini IVF. You monitor, you can see how the development is happening, how the blood flow is, so much information you can have. And if you think your tube is not good, then probably this for either IVF or my previous panelist mentioned either IVF or laparoscopy. But you can hear mild endometriosis might be a factor that is causing damage to the follicle. So also from your scan, you can diagnose those things. Or adenomyotic uterus, you might see, which is not mentioned previously. Sometimes we see later in the cycle. So definitely IUI has got a chance here, provided our patient agree and they understand that the success rate will not be great. Anybody want to add anything in the scenario? Okay, then I'm going to the next scenario, and I'll start from Dr. Shamli. Mrs. X, she's 30 years, married for 6 years, primary infertility for 5 years. History of dysmenorrhea, dyspareunia, AMH level is 1.8 and HSG tubes patent. And the husband semen analysis, the count is 62 million total count, progressive motility 55%, morphology is 5%. So, past history of ovulation induction and IUI 3 times. It's failed. Now what? What next? So, Dr. Shamli. Yes, in this case, what we are going to do? Dr. Shamli? Are you there?
I think this is the small endometrioma, 2.2 centimeter. It does not require any surgical excision.
So which one?
Hello,
Hello?
am I audible now?
Yes.
Yes.
So this is the scenario?
Okay, madam. She's 30
And
years
failed IUI.
age and she's 30 years of age, married for 6 years, and primary infertility of 5 years. History of dysmenorrhea and dyspareunia is there, so that might suggest that she's having some kind of endometriosis, maybe.
Yes.
Her AMH is 1.8, which is not so good, but not very bad also. Her HSG suggests tubes patent, and otherwise her HSA 62 million
Semen
and
analysis is
motility
good.
Yeah.
Hmm.
Ma'am, next slide, please.
So IUI failed still.
Okay, ma'am. Do we have her USG? Suggestive of any kind of endometriotic patches or endometriotic collection in the ovaries?
Yes. Hmm. So how can you improve your transvaginal scan? Anything what you can think of if you are thinking it is a endometriosis?
Ma'am, any kind of hemorrhagic cyst or chocolate cyst
That is
diagnosed on
the obvious thing. That is the if there is chocolate cyst means grade 3, you know. But if
Yeah.
it is grade 1, grade 2, can you diagnose with good transvaginal ultrasound?
Ma'am, if there is any pain felt on transvaginal abdomen entry, any pressure in the POD, then she might have some signs of endometriosis also.
Yes, sometimes we can see sometimes some fluid collection, some band adhesion. So you need to focus in the POD, pouch of
yes.
Douglas, and you zoom in the POD. You can see the structures there. Sometimes nodule, endometriotic nodule. Typically, when there is a uterosacral nodule or rectal adhesion, you can bimanually palpate and you can go in and out and to check the rectal, is the rectum fixed with the uterus or not. So POD can give us so much of idea. Sometimes saline infusion also can give us some idea. Like saline infusion, you check for patency of the tube. If you infuse some saline inside the same way, inside the cavity, then also POD is visible. You can see some like very early endometriosis, flame-like lesion. That is also sometimes floating in the POD. That is also because we are thinking here in the line of endometriosis. So in endometriosis, this case, so already she has 3 times IUI failed. So you counsel probably it is endometriosis, say it is grade 1, grade 2. So other factors are fine. So what do you suggest the patient to take forward the treatment?
Yeah, ma'am, I will suggest IVF for her because considering her age and IUI also failed for 3 times. And we will do IVF first, the ovum pickup, because if we remove any kind of cyst, that might decrease the ovarian reserve.
Yes.
So we will do stimulation first. We will do the ovum pickup, and then we will do the freeze-all cycle.
Yes.
And then we will treat her for endometriosis, and maybe if there is any adenomyosis or something, we can give her GnRH agonist depot preparations for say 2 to 3 cycles, and then we can prepare her for embryo transfer.
And if required, laparoscopy also that time, if you think that is required, then also.
Yes.
So we need to counsel her in that way. Okay, so here TVS, mild adenomatic uterus, right retroverted uterus, and right ovary chocolate cyst of 2.2 into 1.42. That is small. AFC is 6 to 8. Left ovary antral follicle is 8. So you have already done IVF for her. So anybody, I'll go to Dr. Rohini. In her case, have you managed it differently? Do you still plan IUI?
No, ma'am. As she has a history of three IUI failed. Sorry, three IUI failed. IUI failed. Further IUI is unlikely to improve her outcomes. So clinically, apparent.
So how do you counsel the patient then?
Ma'am,
With this transdermal sonography finding.
Along with the sonography findings, her history is also telling that she's married for 6 years and having dysmenorrhea and dyspareunia with low AMH. I will counsel
and
her
now the
to
chocolate
get,
cyst and adenomyotic
clinical
uterus.
outcomes.
Yes, please go on.
Hello.
Yes, go on, please, Dr. Rohini.
Ma'am, her AMH is also on the lower side, like is 1.8. I'll counsel her that it is better to get good success in when we go through IVF cycle.
Yes. So she's the candidate that we need to counsel her, because IVF also not guaranteed for 100%. So we need to counsel her in a way that this is the scenario, because sometimes we know that who have got endometriosis, chocolate cyst, their egg quality also sometimes poor. So do you want to give anything before her, to prepare her body before her IVF? Do you want to improve the egg quality? I will go to my next panelist, Dr. Anuradha. In her case, because you have to do now IVF, so do you want to improve the egg quality? Do you want to add something before IVF?
Her AMH is 1.8. Yeah. In this
So
case,
you do not know about her BMI, do not know other things. So will that change your plan sometimes?
Yeah, if her BMI is high, then maybe we'll tell her to lose the weight by 8%
Lose weight,
or
healthy
10%.
diet, this sort of thing. Anything, any medication do you want to add? Because her low AMH, chocolate cyst, you might not get good quality eggs. So what do you want to do before that, beforehand?
I think her poor egg quality will be because of endometriosis. So even if we add
so
something,
do you want to directly go to IVF, or do you prepare her body before IVF?
Yes, that we'll do because we want to like embryo transfer after pickup. We'll not immediately transfer the embryos. We will
Before pickup. Once the pickup is done and egg quality is bad, then you cannot change the outcome. So before pickup, in her case, do you want to add anything? Any antioxidant, anything? Coenzyme, anything?
Yeah, we can add antioxidants like coenzyme Q10 and resveratrol. And
so that
we
might
can
improve the quality a
improve the
bit.
quality of oocytes.
So if we are adding any medication, we need to give her at least 1.5 to 2 months.
Yeah.
So that the medicine will work, and then we go for the IVF.
Yeah.
So
Madam, will you advocate DHEA also in this case?
So that will depend, because she is 30. So she is 30. If you are seeing a very low amount of follicles, 6 and 8 is quite normal, I'd say 8 follicles and 1.8, I might not give her DHEA. But if suppose it is 4, 5, that type of very low count with a chocolate cyst, so in that case, yes, with coenzyme Q, you might give her DHEA because she is only 30.
Okay.
But otherwise, usually we all add at least coenzyme Q. You mentioned resveratrol, some antioxidant preparation, so that we can prepare her body beforehand. And then you can start her IVF, because after IVF, do anyone give her agonist depot beforehand, before IVF?
No.
So we want to do her IVF. If we are doing, then we want to do it like fresh. So in a natural cycle, we do not want to jeopardize her normal cycle. Okay, because natural cycle is good for her because low AMH. Okay, coming to the next third scenario, and I'll go to, I think Dr. Anuradha has spoken. So I'll go to Piyusha. The third scenario is 34-year female married for 10 years, primary infertility for 8 years, AMH is 2.1, AFC is 8 to 10, and SIS was done, tubes patent, husband count, semen concentration 28 million, and progressive motility 48%, morphology 4%. Now she underwent an IVF where antagonist protocol used with gonadotropin dosage of 300 for 10 days. HCG 10,000 trigger was given for LH Sarge and 4 oocytes only. So here the problem, only 4 oocytes retrieved, and that also 3 M2. An embryo formed, one is 8 cell, grade A, another is slow growing embryo, grade B, and fresh transfer failed. Now what to do? How will you counsel this patient? Dr. Piyusha.
Yes, good evening, ma'am.
Good evening.
Ma'am, in this patient, I would advise her, like, we'll have to go for IVF again.
So she is in the which category of poor responder? Her response was bad, isn't it? So poor responder.
Yeah,
so
yeah,
which category?
yes.
She is Poseidon?
Age is less than 35.
She is Poseidon 1. Actually, she is Poseidon
yes.
1.
Yes.
So we thought she is going to respond well, but she did not respond well. That means she is Poseidon 1 group.
Poseidon 1. Yes.
Less than 35, yes. So now how to counsel?
Ma'am, we'll advise her to go for the next cycle. This time, instead of fresh ET, I would prefer frozen embryo transfer.
But if you get that much of egg and embryo, then only you can do frozen transfer. Sometimes we do fresh ET because the quality is so bad we cannot freeze. So you do not want to go for another IVF cycle. Now she will tell, if this thing happen again, doctor, so what I will do? So what you can do? How you counsel this patient?
Ma'am, we can opt for PGTA if we get the embryos, and before that,
if it is 2-3 eggs, it is not possible. So you need to improve that. So why do you think why this
DHEA?
Add antioxidants.
We'll add antioxidants, DHEA.
So you need to do something. So some change in your management plan, because you see some follicles that is not getting recruited, or even if it is recruited, that is not the follicle to egg number is low. So you have to improve at that stage. So need to think, have we missed anything?
Ma'am, we'll add antioxidants and DHEA in this patient.
Yes, any lifestyle factor, any medical factor?
We'll see her BMI, any associated lifestyle or medical disorders, and if anything present, we'll ask her, like if her BMI is more, we'll ask her to help her in losing weight and lifestyle management, and we'll add antioxidants, and then we'll try again.
Yes, so if I think nobody checked for the receptor polymorphism. Do you check?
No, ma'am.
No. So if you think your the stimulation, how do you change your stimulation? So I'll go back to the stimulation. So she was an antagonist protocol with gonadotropin. Here I have not mentioned. So probably suppose it was HMG 300. So do you want to change your protocol somewhere?
I will be using FSH, combination of FSH and HMG in this patient.
Yes, sometimes recombinant might give in this case because it is probably receptor is not working with that thing. Either you have to increase the dose, or you have to change the type you are using. It was HMG, so you change it to the recombinant, as you mentioned. Recombinant LH. In these cases, sometimes recombinant LH is very helpful, though nowadays we do not get recombinant LH separately. Recombinant FSH LH combination pargoveris is available in those cases where we think we are not getting enough number of eggs, but the follicle, antral follicle and AMH is good, like Poseidon 1. So in that case, you have to change something. You cannot just repeat the cycle the way you did last time. So you have to do something else. Okay.
Yes.
So you might increase the dose. If somebody was on 300, you might increase to 375. It might improve your chance of number of recruitment. Okay, so check if the affordable patient parvovirus is good because both are recombinant. That sometimes give you a good number of eggs. So you need to counsel the patient in that way, and we can go for the stimulation. We need to change something. Otherwise, same thing you cannot repeat because we'll end up with same. Okay, I'm going to the case scenario 4 with Dr. Prachi.
We can change trigger also, dual trigger.
Sorry, yes, dual trigger.
Dual trigger
Dual
will be
trigger is
preferred.
also good,
Yes.
definitely.
Dual
So we
trigger.
can change the trigger. Dual trigger is good. Okay. So we have to change. So whatever we have done, we have to change something. Otherwise, we should not repeat the same thing. Okay, coming to the next topic. Next case is Dr. Prachi Agarwal. So
Yes,
next
ma'am.
case is, yes. So Prachi, this is a 28-year-old, married for 4.5 years, primary infertility for 4 years, regular cycle, MH is good, 3.4, HSG showing patent tubes, husband count is good, 80 million, 80% motility, normal form also 80% they have mentioned. So, husband age is 42, smoking, occasional alcohol intake. Now, how to proceed?
Ma'am, in this case, female criteria are good, but husband is a smoker, so we should go for the DFI in such case.
Yes. So, do you
with
think
semen
this
analysis and
report
DFI.
about the husband semen analysis report? Do
Ma'am,
you think
report
is it
is good.
possible? Normal form is 80%. I have mentioned.
Yes, ma'am. The report is good, but husband is a smoker. So many time it
No,
affects
sometimes
the
that what I'm saying is interpretation of the report is also not good because it is the written report we are seeing. We are not ourselves seeing the slide, isn't it? So
Yes.
sometimes if you think the normal form, the cutoff is so low, 4%. So if it is 5%, 6%, we say super sperm. So in that case, normal form is 80%. Sometimes this is not a right report. So we might change the but we can say ask the patient to repeat from another reputable
Good
or
quality
reliable lab, isn't it?
Yes, ma'am.
Yes. And husband is 42. Yes, you were telling about the lifestyle modification.
Yes, ma'am.
So other than lifestyle modification, though you are thinking that might be might not be that good, but you are getting a very good report which is not corroborating. Then repeat the from a reliable lab so that we get because we know that everybody is not all the lab is following the WHO criteria. So there can be some report which it is normal and we all have experience on the day of IVF they give us a sample which is so bad and we are not prepared for it. So always it is better to check before we do that thing. So okay, HS husband semen analysis in the andrology lab, the count shows that 56 million and the progressive motility is 13%, morphology is 1%. So it is called asthenoteratosus per. Now the scenario changed. So it was first 80% normal, now it is 1% normal. So how do you proceed then?
Ma'am, with such report, DFI should be done.
Yes, DFI because he has got all the addictions. So we'll ask counsel regarding stopping all the addiction and DFI. Yes.
Yes, ma'am.
And suppose the DFI is high, 34%. So,
ma'am, the main thing is then we will go for the antioxidants for the husband and we'll ask him to stop smoking. And then we will repeat it again in the 2 months because it will actually take 2 months to improve. Then if it improves or if doesn't improve, if it improves then it's good. If it doesn't improve, then the only thing we can do now I use in my lab some sperm sorters at the time of IVF just to get a good quality sperms.
Yes. So different sperm sorters are now available. So that can give us a good sample. So from the count, we can get a morphologically good sperm. And do you want ICSI for this patient if the DFI
Definitely,
is that
ma'am.
high?
ICSI. Definitely, ICSI will be done, ma'am, in this case.
ICSI will be done because there's sometimes chance of fat failure if the DFI is very high. So we'll counsel the patient in that way. So what we can do ICSI, but how to select the sperm with sperm sorter as Prachi has described. Okay. Okay, so husband further evaluation, BMI is high, 34.6, erectile dysfunction, HbA1c is 6.4, and the PPBS is 156. So, do you think you can change this scenario in a way?
Lifestyle modification is mainly required for this person.
So all the blood erectile dysfunction, HbA1c 6.4 and PPBS suggest he is suffering from
Diabetes.
yes, diabetes, or you can say pre-diabetes.
Mainly
Okay, so
is pre-diabetes.
yeah, so improving that also will improve the not only the only medication. So improving his diabetes and weight control, BMI control also give us good result, and DFI might improve, erectile dysfunction might improve. So we need to counsel the patient in that way that if your diabetes sugar control improves, all these things will improve. Now you how to proceed. I think all of things are discussed. So we are going to our case scenario 5, and I will start from Dr. Archana. She is Mrs. G, 33 years, married for 3 years, trying to conceive for 8 to 10 months, and regular cycle, BMI normal, TSH prolactin normal, tubes are patent, semen analysis mentioned as normal. Now USG suggests that polycystic ovary-like morphology. It is done from somewhere, and AMH is 0.3. So do you think it is tallying?
This is very contradictory thing. It means PCOS, polycystic ovarian morphology, and AMH is so low.
0.3.
Contradictory.
So who is right? Yes.
Yes.
Because she has got a regular cycle as well. 33. Yes.
And
yes.
This is the low ovarian reserve. It means low ovarian reserve. So management.
So she cannot be PCOM, isn't it?
It is not a PCOM, I think.
Yes, but sometimes you see in the outside where the doctors are not doing trans TVS by themselves, somebody else is doing. Sometimes they report few follicles they see in the ovary, and they mention this as PCOS, so PCOM. So it's not a PCOM if the MH is so low.
Yes.
So we have to be very cautious, and we need to do our TVS by ourselves. Otherwise, the patient's time and money will be wasted.
Right.
Okay, so transvaginal scan you have done by yourself. You see 2 follicles in one ovary, 1 antral follicle in another ovary.
Yes.
Now, so she was thinking she was PCOS. Now you are saying you are POF. Okay, so how to counsel the couple? So Dr. Pratibha, do you want to take the question? How to counsel her? Dr. Pratibha?
It's not available.
Are you there? If Dr. Pratibha is not available, then Dr. Akanksha, can you take the question? How to counsel her from PCOM to low reserve?
Yes, ma'am. I will counsel her that her AMH report is 0.3 and AFC is 3. So AMH and AFC both are correlating. And now depending on
so the previous report is not right, isn't it? So PCOM, so she is thinking I am having polycystic ovary, so that is not right.
That is not right. So first of all, I'll have to tell her that there are no cysts in your ovary, but in fact, your reserve is less, and now we need to hurry for the treatment. Since
Yes.
your age is less and reserve is also less, there is a good chance and fair chance that we will get a genetically euploid embryo in your case. But for this thing, so you need to go for IVF now immediately. No need to waste time over other things. And another thing is that you might need more number of cycles, that is embryo pooling. There is
Yes.
a possibility that
Very
there
good.
will be no
Yes.
response during stimulation. And there is a possibility that there might not be embryo formation in spite of good ovarian response too. So I'll mentally prepare her for all these things, and then we'll do IVF in her
Yes.
case.
So in her case, probably we can try some DHEA before stimulation. Somebody was asking because she is very
Yes,
young.
ma'am.
So for her, probably 1-2
Yeah.
egg, but that can give us good embryo, euploid embryo. But embryo pooling is good for her. She might not achieve enough number of embryo in one cycle. She might need 3 cycles to get 6 embryos. So that is the way we should counsel the patient. Very good. So I'm going to the last scenario. This is Mrs. B, 34-year, married for 10 years, primary infertility for 8 years, regular cycle, AMH normal, ultrasound normal, HSG tubes patent, husband semen analysis normal, underwent IUI 4 times and failed to conceive. Now how to proceed? So my next panelist is Dr. Shamli.
Hello. Yes, ma'am. In her case, her age is 34 years, and other reports are good. Her AMH is also good, and HSG tubes patent, HSA is normal. But she already underwent 4 cycles of ovulation induction and IUI. So I will tell her that we have already gone for 4 cycles of IUI. So we should better go for IVF. But before that, if we can do her laparoscopy and find out some factors which are unnoticed in her case.
Yes. And hysteroscopy as well, isn't
Yeah,
it? Sometimes
hysteroscopy,
hysteroscopy also give us some idea.
laparoscopy we can do. And then we can proceed for IVF. So that
Yes,
will be
if there
beneficial
is
for her.
anything, counseling is very, and she's counseled and she's agreed for IVF. Now, IVF antagonist protocol, standard stimulation 300, given, suppose HMG and PV transvaginal scan, you see fluid in the endometrial cavity during stimulation. So you have done OPU, freeze all embryo due to the persistent endometrial fluid. Now you are planning for HRT. HRT transvaginal scan again done on day 12, 7.2 millimeter endometrium with fluid in the endometrial cavity. I think Dr. Shamali already mentioned that she is a candidate for, though the tubes were put in.
Yes, ma'am.
Hysteroscopy give us some idea because it is very common scenario. Sometimes we are stuck there because of the fluid.
Yes, ma'am.
So, Dr. Rohini, do you want to add anything?
Ma'am, in this case, she has been started.
So, fluid is due to what you think?
Fluid. Ma'am, we have to identify the cause, whether she is having hydrosalpinx, chronic endometritis, or cervical scan, which we can do with the good TVS scan. We can rule out hydrosalpinx. And chronic endometritis and cervical stenosis, while doing diagnostic hysteroscopy, we can identify the cause. If she
Sometimes if she is, don't say about diagnostic hysteroscopy, because sometimes the mild, very small polyp is there. So you need to cut it as well. So it can be operative if you see something.
Yes, ma'am. Isthmocele or
no, isthmocele is, she is a she never had, she never conceived, so isthmocele is not possible.
Yes. If she had a previous history of cesarean section,
then but here, yes, sometimes tube and it is, sometimes you see some. So how common is tuberculosis in this case? Do you think tuberculosis can be a cause of this?
Yes, ma'am. As in India, tuberculosis is very prevalent. So tuberculosis might also be one of the cause for this scenario.
Yes. So sometimes that's why laparoscopy sometimes give us more idea. Hysteroscopy, you might see some adhesion bands, and laparoscopy sometimes you can have an idea of tuberculosis if there is adhesion, some tubercle on the omentum, or you see something cocoon. Sometimes everything is stuck.
Yes, ma'am.
Yes. So and sometimes hepatic area also we need to see here. When we there also some fiju cut is kind of a appearance can also get us an idea about the infection and
tuberculosis.
Yes, tuberculosis. So rule out infection. Yes, we will rule out the infection because we have to transfer So do you think any role of probiotics? I'll go to my next panelist, Dr. Anuradha.
Yes,
Any
ma'am.
role of probiotics for her?
Yeah, yes, but before that, once we have found the fluid in the endometrial cavity, we have to do DICE test.
Twice, yes.
Sometimes the DICE test also can give us
Give
exact
us an idea of infection.
yeah,
Yes.
idea of infection.
So probiotics, do you use routinely for FET preparations
Yes,
or
yes.
during IVF?
Yes, we are using it during
Yes.
FET preparation.
So actually, before starting, we should start probiotics because it will improve the. They are saying 3 months, but at least few months means during the start of stimulation. Also, we need to give them probiotics, and especially we are going from down to up, that is vagina. So there can be some infection. If this is infection unknowingly, we are introducing the infection in the pelvic cavity. Then,
yes,
isn't it? So role of probiotic is important. I think anybody want to add anything? We are at the end of our slide. Anybody want to add anything?
Ma'am, many of your slides were showing disparity between AFC and AMH.
AMH, yes.
So I think with when infertility specialists they're doing scans themselves, then they have to rely more on AFC than AMH.
Yes, yes.
AMH sometimes lab to lab variations are there. And if the patient is on down regulation for 2-3 months, the AMH may vary
yes,
cycle to cycle. So
yes.
I feel that if we are doing scan ourselves, we should be sure
Yes,
what is her AMH.
yes, definitely. So that is the purpose of this panel discussion. So we need to do our. Otherwise, we will be fooled by the report and like the husband analysis, same analysis also. Sometimes they are saying normal, and when you see in your own lab, you see the poor result. So that's how any last if all our panelists give us a one-line answer for an unexplained infertility, what you need to think. We start from Dr. Archana.
Yes, so if you do like all the if you evaluate and everything is normal, but we open our eyes towards other things like
Yes.
AFC, AMH.
Yes. Again, recheck. Dr. Pratibha. I think not getting Dr. Pratibha. Dr. Akanksha, are you there?
Yes, ma'am. Ma'am, for unexplained infertility, IVF is like a therapy also and like a diagnostic tool also. So first IVF cycle can be an eye opener and it
Yes.
can tell us many things about the quality of
Yes,
oocyte and
absolutely.
embryo formation and rate of embryo growth. So
Absolutely.
that is the thing we have to tell
Yes.
to unexplained infertility.
Okay, thank you. Dr. Shamali?
Yes, ma'am. Actually, all the investigations, interpretation of the investigations, everything should be proper in case of unexplained infertility. The scan should be done by ourselves, and the investigation should be done from reputed laboratories, and then only we can proceed. So that is also important.
Yes, Dr. Rahini?
Ma'am, unexplained infertility doesn't mean that there is no cause. It means current investigations fail to identify the cause. So we need to
Absolutely,
identify
yes.
the cause.
Then
And
only we
then
can
treat-
improve it. Yes.
Yes, yes, ma'am.
And Dr. Anuradha?
Ma'am, many times we have seen that in unexplained infertility, we are missing out something. So diagnostic laparoscopy many times gives us that
Give us
surface
an idea.
endometriosis or small
Tuberculosis or
intrauterine
something, yes.
adhesions. And
Additions,
yeah,
yes.
flimsy adhesions. All these things
Yes.
can be taken care if before IUI, if we are doing laparohysteroscopy and then going for
Yeah.
IUI superovulation.
Yes, yes.
Many times we
Yes.
get results.
Yes. And Dr. Piyusha?
Ma'am, in addition to all the points that have been said, discussed right now, lifestyle management should be focused on.
Absolutely,
With
yes.
increase in unhealthy lifestyle, it is important that we focus on lifestyle management. And
Yes.
also for semen analysis, days of abstinence should be explained properly to the male partner and should be taken care of. Because this week only we got 2 patients who had done the report from outside, but they hadn't been explained about the abstinence days. So that is also important.
Abstinence is not that important. If there is no abstinence, the volume of the semen will be low, but concentration and motility should not affect, and the morphology. So these are the main factors. But yes, total count can be low, that does not matter. But if the concentration, morphology, and motility is good, then also it is good. Dr. Prachi?
Ma'am, we need to, even IVF is a blessing. In one of my patients, even there were 2 failed cycles in unexplained infertility. And we went for PGS, then the patient conceived. So just keep trying and things will work.
Yes, yes. Thank you very much. Thank you, my panelists. So I will hand over the session to Dr. Our MOC and Dr. Kalpana ma'am.
Yeah,
Thank
it
you.
was a wonderful discussion. I really enjoyed the case and also experience of our experts. It was wonderfully done, Suparna. Thank you so much for joining and doing wonderful panel.
Thank you.
Thank you.
Thank you, Dr. Suparna ma'am. Very interesting discussion. Next, we'll move on to the next panel discussion. I invite the moderator, Dr. Suvarchala Chekuri, who is the scientific director, Ziva Group of Fertility Centers. She has done MC from Monash University, MSc Clinical Embryology, Leeds University, and PhD Genetics in Genetics. Previously, she was the Pan-India Scientific Director, Apollo Group of Fertility Centers, and Lab Manager of Nova IVI.
Thank you, ma'am.
Thank
you, ma'am. Thank you very much. In the interest of time, and since I know all the panelists very closely, I have worked with them, learned from them. Very quickly, I will introduce them. This is Dr. Deven Patel. He is Chief Embryologist with Sunflower Women's Hospital, Ahmedabad. He has a lot of accolades. The next embryologist is Dr. Shashi Kumar, a very dear embryologist with lots of experience from all over the world. Next, ma'am. This is Dr. Dhanya. She is right now an embryologist in Chennai, if I'm not wrong, or is it Kochi, Dhanya? Correct me if I'm wrong, because we always meet in conferences, but I've gathered a lot of, good information from her, good knowledge from her. Thank you for that. Next is, ma'am, can we go to this is Dr. Fairy. She has had very good and rich experience, and you can see her education, her qualifications are also very robust. She was taking care of Apollo Fertility in Hyderabad, and that's how I got to know her. She's very good with ICSI and freezing, because we've encountered a lot of, I've seen a lot of patients coming from her, mine going to her. So we used to do a lot of discussions about this. Thank you. Dr. Suhasini, she's an embryologist with 15 years of experience, and she's right now heading Rainbow Hospitals, Birthright Fertility. And you can see on the screen, she has a lot of feathers in her cap. So may I begin, ma'am?
Yes, please.
It's just that I wanted to spend more time on the slides, since we are already.
Yeah, that is really wonderful, Suvarchala.
Yes, ma'am. We are already running short of time.
Yes, yes.
Ma'am, something is. I'm using an Apple. Why is it not working? Share screen.
Sahiti?
Can someone help me with
Yes,
the share?
yes,
I'm
ma'am.
using a Mac, ma'am.
Yeah, yes, ma'am. You can share, ma'am. At first, open the PPT and minimize it, ma'am. And then come to Zoom, click on share screen.
Hold on.
And then click on entire screen tab and then share.
Hold on, ma'am. I need to close
One
a
by
lot
one.
of tabs
Yeah.
that
Sure.
got opened. I'm sorry about this, everyone.
Is it showing any error, ma'am?
So you told me to go to the PPT first, is it?
Yes, ma'am. At first, open the PPT and then minimize it, ma'am.
Okay, ma'am.
And then come to Zoom.
Yes.
Click on share screen option.
For some reason, it is saying Google Chrome would like to.
Or else you can search share screen in more option.
No, ma'am, it's not there in more also.
There will be share option, ma'am.
Yes, I can see the share. I always do the share, but somehow it's.
Okay, I'll make you
Hold
go.
on, ma'am. Yes, I got it. I'm sorry about that, everyone. Can you see my screen?
Yes, ma'am, we can see now.
Wonderful. Thank you so much, and I'm very, very sorry for all this. Now, embryologists are boring people talking only to embryos. We are lonely, we are frustrated. We see a lot of things in the lab that we wish most of the times we don't. But there are things that we need to talk about today. And at the end of this panel, I'm hoping that we can get a lot of information from each other's experiences, because it's all about a constant set of work, definitely. But each case is different, each egg is different, each sperm is different, and so eventually the embryos are different as well. We encounter a lot of different scenarios, and I would like to pinpoint the ones that are most critical in the interest of time, of course. Why is it not going to the next? It's not going to the next. Yeah. My first point is poor fertilization and failed fertilization. So we open the incubator and find less than 30% fertilization or complete fertilization failure. I'd like my panelists to walk us through the immediate response and what does evidence say? What in your experience is the reason for it? Can we begin with Dr. Deven?
Yeah, so as you know, when we see these kind of scenario, we are really worried that something is wrong in the lab. First, we
Absolutely.
always think that okay, something is wrong, or we have changed something. So what we do, like as we are discussing, we'll be sharing some what we are doing actually in the lab. So
Yes.
initially, I would like to complete my gradation of all the embryos of that day. So basically, I will check for checks, then day 3, then day 5, whatever checks are there, I will do that. That will give me a fair idea that is it the patient factor or is it the lab factor. If it is happening with lot of other patients, definitely I will try to find furthermore in the lab. But if we see this is only the case, this particular case only is having failed fertilization or poor fertilization, that gives me idea that maybe this is something wrong with the patient. Then we shift to the clinical side. Then maybe I will like to check what was the quality on the day of ICSI. If somebody who has done ICSI has mentioned that there is a SERs or whatever, the quality of the oocytes. And if not, then I will go to the sperm factor also. And simultaneously, we'll see the age of the patients or what are the other factor like POR, poor responder, or maybe the PCOD patient. So where we may find these kind of scenarios.
Yes. Yes, that's very interesting. So you've covered everything. You said you will look at, not just that particular patient, you'll go on to look at everything in the lab that's happening, all patients. That's a very good point. Would anyone like to add to what Dr. Deven has said before I tell you what studies are talking about?
Good evening, ma'am. Namaste, everyone. So, ma'am, sometimes even AOA works very well with fertilization failure cases. Very few cases, but yes, oocyte activation and AOA really works sometimes well.
Okay.
Dr. Subachla, I just wanted to add one point. As you said, once you open the incubator and see all the injected eggs or IVF done eggs are unfertilized.
Right.
And first thing that Dr. Deven said, we wanted to just rule out from the lab side. We just check all the plates and we see the embryogenesis of other patients. then we'll go back to the patient, and we also look into the male factor involvement in the case. If the case has a severe male factor, like, high DFI index, kind of more than 40%, and it is not testicular sperm, we have not done any intervention with that. And then we may have to give a thought on, male factor as well. And usually, total fertilization failure in IVF cases, we see 5 to 10%, and ICSI cases, closely 2 to 3%.
Right.
And in decision making, I think history of the patient and background of the patient really helps us.
Yes. Yes. So very quickly, let me tell you what, data from everywhere is talking about, because this is simply a blind date. And again, a sperm expected to meet each other, and then we come the next day, they haven't. So what is it that studies are saying? When there is an impact on fertilization success, this wonderful study, which I gathered, and I'm trying to summarize everything very shortly, that most of the problem comes from the sperm. Dr. Suhasini, that was a very good point that you raised, because when this happens, most of the times it's the sperm that's contributing to the fertilization failure. Of course, like Dr. Deven said, number of factors are there, no doubt about it. But as you can see, 84.1% of the cases that were taken up in this study, they highlighted that it was because of the sperm. This also means that semen analysis then is probably not a very reliable predictor of fertilization success, I'd rather say, because in the lab, then we think that once we do the semen analysis and all the parameters are good, there is something more that is happening which is escaping our eyes. Then should we be doing IVF? Should we be doing rescue ICSI at all? Well, just rescue ICSI on its own has been shown to not be very fruitful, but in certain scenarios with certain terms and conditions, if this is applied, probably it could have a little bit of success. I have not done it personally, and I would like my panelists to say, highlight if they have ever, because this study, it was a wonderful meta-analysis, threw light on the fact that if you went for a frozen embryo transfer, there was a chance of success, but not at, at that level where suddenly you came and there were no fertilized oocytes, and you had to inject and then do the transfer in the fresh cycle itself. So yes, all the points that Dr. Deven said, and as Dr. Suhasini pointed out, it is also the sperm factor. In fact, it is mostly the sperm factor, because if you have standardized your lab, of course, there are things that you can't control. But if you have standardized your lab, more often than not, studies say it's the sperm factor. So was the sperm preparation appropriate? Was the injection technique consistent? Did the oocyte maturation assessment happen properly? Because many times I have noticed too that the cumulus is so tightly packed that I'd rather not use a fine bore and damage the egg. So sometimes, the polar body is not very clear. So was this done as well very, very clearly is one of the points. The second thing is high embryo fragmentation. This is something very important. We all encounter this. You are seeing unusually high fragmentation levels across multiple embryos in a cohort, let's say around 25 to 30%, which you will all agree that it is quite high. What are the most likely causes, and what interventions are you going to take? What is it that you're going to look at clinically? Dr. Shashi, can you take this question?
Yes, madam. Good evening to everyone. Thank you, madam. Actually, based on so far our experience, fragmentation in all the embryos, actually, because of the reason it might comes from oocyte or contribution from sperm as well, actually. There are some embryos, actually, if for out of 10 we are having a fragmentation only few embryos, then we can say the factors from maybe from our laboratory, or maybe a cause of from our side, actually. Otherwise, if you are seeing the fragmentation every embryos, then definitely I would say like it's from contribution of oocyte or sperm, actually. And recently we have seen in our cases, actually. So in such cases, we will wait until day 5, and we see if there is a progression in the growth, and if embryos are reaching to the blastocyst, then we will use them for the transfer or freeze. Otherwise, definitely we will discard them, actually. So it is like causes comes from oocyte or maybe from both of them actually, like oocyte and sperm as well actually.
Right. Dr. Suhasini, would you like to add anything to this?
Yes. I will not 100% agree with Dr. Shessi's statement in this. If a few percent of the embryos have high fragmentation and the rest all is looking normal, it may not be the lab factor that is involved. If at all, if any lab factor is involved, it is uniformly damaged. If the oocyte, I mean, in a cohort, not all oocytes are, say, like genetically normal. Each oocyte is different, though it has come from the same cycle. Each
Cohort.
oocyte has its own way of development. So it may be other way around, I feel personally. Secondly, if I see high embryo fragmentation, like there are gradings. If you see 10%, it is as good as normal division. If it is more than 25%, as you mentioned, then that is the situation where you have to really panic. So in that case, first thing I think about is egg quality, maternal age, and then I go for the sperm DNA fragmentation. I will again think about my laboratory conditions in terms of VOCs and oxidative stress. And then I also look into the percentage of fragmentation. Then I'll take a decision. Usually, if in case of high fragmentation, we don't want to freeze them on day 3. We wanted to culture them till day 5 to see how they are going to cope up with the blastulation rate. If they are doing the self-correction and if they are progressing to good blastocyst, that's a good sign. If they are distinct to arrest at day 3, we will have an answer. We don't want to go for a blind transfer on day 3. We wanted to see complete embryogenesis and take a decision as to what to do with the cycle.
Right. Would you want to do the analysis over a period of time? Like it's not just that day that we panic, right? You do this over a period of time, say a week or a month before you take action, or will you take it the same day?
I mean, if it is happening consistently with all the cases, that means there is something wrong with the laboratory. I am talking in terms of the case specific.
Right.
If it is like a, in a batch, I'm observing 50% of the cases falling in the same scenario, then there is nothing is wrong with the thing. Grossly something, unforeseen things are happening in the laboratory. I have to find out where it is actually going wrong.
Right. There are a lot of things that we need to, the
Yes,
checklist
yes.
is extremely long to be covered in a panel today. So what is happening? This systemic review, it was a very good study that I, happened to chance upon. And it says that more often than not, it's the gamete quality, definitely the sperm and the egg, like both of you pointed out. It's the oxidative stress which comes from the lab and a lot of more factors that are at play, culture conditions, and these are the most important causes of fragmentation origin. This is what I'm talking about of this study. Of course, we all have gathered all this from the time-lapse techniques that some way or the other we have touched in our professional careers, and that's how we have gathered that how these fragmentations occur, and then we can trace it back to what kind of clinical diagnosis was there for this particular problem. But definitely, if it is a cohort, then take quick action. If it is a particular case, go back and look at it clinically as well, is what is important. Also, high DNA fragmentation, this study says that it is associated with not just cleavage delays in blastulation, but also in fragmentation. So maybe that's a factor that has to be looked as well. And more often than not, we don't look at DNA fragmentation, at least in the centers that I have worked in, because it was too expensive and patients could not afford it. We did not conduct DNA fragmentation tests as a blanket rule. So maybe a hidden cause could be DNA fragmentation as well. Now, so review the culture media lot, like it has to be looked at. Check all the incubators. Of course, all the checklist is long. The quality control has to be done. Not just the oil quality. I meant that it should be the entire system of where the media was stored to how the dish was made. And definitely consider sperm DNA fragmentation. Of course, it's not possible to do it to all cases. Can I move to the next question? to the next case?
Yes.
Yeah, yes, ma'am. Yeah.
So the next is embryo developmental arrest. Your embryos are arresting, and this is not just a particular case. I'm talking about the lab and a few cases that are happening where they're arresting in 4 to 8 cells, and they're not progressing to blastocyst. And this is happening across multiple patients in the same week. So what is your approach in diagnosing this problem and fixing it before you move on to the next batch of pickup? I don't mean in batches, but the next week of pickup. Dr. Danya, would you like to answer this? And maybe Dr. Fairy can also contribute.
The embryo developmental arrest, I think this is like a shock if I see arresting many patients and many embryos at the same time. So if that's the case, and if it's observed over multiple patients, then definitely we should look into the lab atmosphere. If there is no VOC, I mean, if you don't have an equipment, outsource it. And if you don't have an equipment, make sure that there is no painting or anything happening in the nearby areas. Just check on your air quality and then check on your incubator, your pH levels, and the temperature and your media. So that would be my first this thing. And if only if it is isolated to one particular patient, maybe you can think of aneuploidy in that patient. But when it is over multiple patients, it points fingers to the lab, I think.
Right. Dr. Fairy, would you like to add to this?
Yes, ma'am. Yeah, so I very much agree with what Dr. Dhania put out the points out. If it is happening with a particular case, we can go into screening of chromosomal anomalies as well. And poor gamete factors also are involved a lot, especially if we talk about andrology side, the DNA fragmentation indexes. And very importantly, what would I do if I had this scenario kind of mini attacked with embryo development arrest? I would definitely discuss with my clinician, reviewing whatever the stimulation protocols, and mainly also, as we all know, being embryologists, the temperatures affect our media so very well. And we are very sure of what medias we are using and what temperature we are maintaining before use, after use, whatever. Similarly, the injection timings and what are the injections, what temperature they are stored as. This is also, like I have practiced this. I've gone and talked with the nursing team as well and reviewed with my clinician. This is the point I want to put forward. Wherein continuous embryo developmental arrest is seen in particular case or multiple case again, then these are the scenarios which I would look into, definitely.
Right. Dr. Devin, would you like to contribute? Dr. Devin?
Yes, I would like to add some 2 points here,
Yes.
rather sharing the experience. So in one of the case, one of the center, we were able to see that somebody doing QA/QC check, they were using the Mink and they were using the filter. They opened the filter and then they checked the gas and they forgot to put back the filter.
Okay.
So unfortunately, there was interruption of gas supply. So I
Right.
think this is also one of the point you should remember. This can have an effect. There was total
That
disconnection
seems
of
very
supply.
minor, but can have a huge impact on all the
Exactly.
all the embryos.
And yeah, that was the one experience. And second experience, similar, like somebody in the night time, the cylinder was empty and some new person, instead of putting trigas, they changed to, I think, oxygen.
Okay.
So
That's very sad.
unfortunately, gas is also are very important to maintain the pH and to know that this pH is maintained in the culture
So
conditions.
so true. And I would like to just reiterate what you've said and enforce what you've said. That is just not the CO2 concentrations, but also the shift in pH that we can cause. So it has to be looked at, because then the embryo development is compromised.
And I
Temperature
think oil also. So one of the incidents like 2 years back, certain company, there was a problem with the oil. And on day 3, there was arrest and they were not growing to day 5. And then later on, it was found that it was actually the oil batch. So I think oil batch is also important.
Correct. So yeah, the lot, the batch that comes into the lab, tracking it, and then observing how the embryos develop from that particular batch of oil and media as well. So yes, all of you said temperature, CO2, definitely most important factors, in addition to a number of other important factors that we deal with. But we have the Cairo consensus guidelines, very, very nicely put, that CO2 measurement is not just the only thing that we need to look at. There are a number of things when we look at the particular culture conditions. So it's the pH. Different incubators have to be validated differently, and especially when culture medium is changed, or the new medium comes, the lot has to be properly assayed, not by us but by the company that's supplying. We can't do the assay all the time, but it has to be maintained. It's not just all of this. Oxygen has to be the oxygen tension should also be critically maintained. This is what the Cairo consensus briefly has. I've just summarized it very, very briefly. Now, what about day 7s? Can someone very quickly tell me what is their experience with day 7 blastocyst, because you did not see anything on day 5? Dr. Suhasini?
Blastulation that was delayed, and we see the blast at day 7.
Day 7, and you have transferred it on day 7, or you've frozen them on day 7 and then done a FET. What has been your experience?
Yeah, I mean, we have seen till day 6. Day 7 is extremely unusual scenario. I personally, I didn't do any day 7 transfers so far. But I mean, the communication, the syncing with the endometrial lining is also equally important in case of day 7 transfers. I don't have any experience with the day 7 embryo transfers.
Right. Dr. Deven, do you have any experience? Because
unfortunately, we have frozen very recently a couple of embryos, but unfortunately, still now transfer is not done yet. But yes, in cases where you see that there is very delayed blastulation and the quality seems to be still good on day 6, I would like to go to day 7, and at least in PGT cases.
But yeah, okay. But why would you like to go to day 7 when you think that they're okay on day 6?
Not okay, means kind of they are early blastocysts.
Think they will survive. All right,
yeah, they will survive. Then only we'll go.
Right.
Not in all cases.
Ma'am,
Yeah.
I've had an experience with a patient on day 5. Blastulation was very less. Out of 6 embryos, we had this one, and that was a 5 BC. So I did end up freezing that particular embryo. But on day 6, when I checked, there was one which was morula. But on day 7, it was late. But on day 7, it was a 5 AB. So then I ended up freezing. Just because I saw a morula on day 6, I thought I'll check it on day 7. Usually, otherwise, we wind it up on day 6. But this particular patient, then we did transfer for that patient with this 5 BC and the day 7 embryo together. The patient had single, but you don't know which is the origin. But yeah, we did end up doing that.
So we work so much on experiences. But sorry, Dr. Shashi, did you want to say something?
Yes, ma'am. Sorry, previously my connection was interrupted. Actually, I'm in
Please
particular
go ahead.
area.
Please go ahead.
Yes, ma'am. Actually, generally, as Dr. Danya was saying, we used to freeze actually on day 6. We end up the case with on day 6 actually. But if not growing until day 6, then we'll allow for them until day 7. Then most of our cases so far, whatever we did, we have frozen actually.
Okay.
As
Did you
usually
transfer as well?
used to discuss. Very rare, madam. Actually, we used to discuss with clinician, and also we explain the patient, and we freeze them. But the transfer was those cases we done for the very, very, very less number than what we've frozen actually, because we know that the result is not good actually as much we compare to day 6. But the reason for the freezing, there is an option, there is a condition is such a condition that we have to freeze actually. That's the reason we used to freeze them actually.
Understood.
Yeah.
Yes, very much as you all have mentioned, these day 7 blastocysts have a very low prognosis, and in terms of either euploidy rate or even pregnancy outcomes, as this meta-analysis very clearly pointed out. But they have also considered transferring them because they can achieve viable pregnancies in the absence of any embryo at all. So that's what the study says. Definitely, when such a thing we encounter, we again back to arrested embryos, immediately audit the incubators, all the factors that are, just not CO2, oxygen, temperature, everything. Then check the media lot numbers, like Dr. Deven very clearly pointed out. It could be the oil, it could be anything. Then uh, assess whether the arrest is confined to one incubator if you have only one. And if it is a box incubator with different lids also, and you have separated them, it is happening in all the incubators, then it could be the gas supply or anything, as Dr. Deven very clearly pointed. It could be at any level that the mistake might have happened. The next, sorry?
Sorry for interruption. Recently, it was happened because of the media batches, madam. Actually, we were allowing them until day 6, but still the embryos were reaching to only early blast. Actually,
all right.
then we found it. There could be some reason of the media. Then we changed. Then we got good good growth. We achieved the blasts on day 5. Actually,
that's
so as you all said, maybe the reason it can come from the even media as well. Actually,
got it. So the next fear that we always face is the low blastocyst formation rate. We have been seeing 50% in wonderful papers, 60%, 70% blastocyst formation. But this is the biggest fear we have. What happened? Why did we not get blastocyst? What could be the reasons for consistently not having 50% blastocyst at least? And would you agree with me, Dr. Ferry, that that is the minimum that we are looking at? Dr. Ferry?
Absolutely, ma'am. Definitely, this blastocyst formation, it is like in correlation with the oocyte quality and maternal age. What we look at, that's what the data also says. But also, the suboptimal culture conditions are very, very important. The laboratory environment that we are used to, also the sperm selection techniques also. Me and my colleagues in the lab have faced this for a while, and we were not able to crack out what exactly is happening and why we are continuously getting with number of cases low blast rate. And this point is very much clear and validated what my colleague panelist just mentioned, that the culture media batch. And that is what we cracked it when we changed the culture media, and then we gradually started getting good blast rates. So that is my call on low blastocyst formation.
Got it, got it. An open question to all panelists. Have you used both single and sequential media? And what has been your observation? Which was better? Open question, quickly take it so that I can go on to the next slide.
So yes, I have used both, and I think with single step media, I will be like in favor of single step media. The quality of blastocyst seems to be better.
Very nice. Would you like to change it on day 3, Dr. Deven, or would you like to do constant culture till day 5?
No, I would like to change on day 3, and also currently I changed to day 5 to day 6 also. So there are some EBLs, those I will definitely like to change on day 5 also.
Okay, got it. Anybody else wants to contribute to this?
I also would like to go ahead with single. Off late, we are actually very comfortable with the single. If you ask the same question 5 years ago or 6 years ago, we used to,
so true.
so we used to wobble between the single and whenever we have problem with single, immediately we used to order sequential for yeah. So
Agree.
now I think it is standardized very well, and we are all very comfortable with single media.
Absolutely.
And I personally, I don't even change on day 3. I try to not to take embryos out of the incubator. I don't directly on day 3, and if it is continuous culture, day 5, and there is no disturbance in between. So I'm not seeing any kind of abnormal embryogenesis with the single step media. It's been almost 3-4 years. It is beautifully standardized.
Very nice, because exactly what you are observing in the lab is what this paper said about 10 years back, that it's nice to have a single medium. Change it on day 3 definitely, and you will get more blastocysts.
Can I share something?
Yeah, sure, Randy.
Yes, actually, I don't want to mention particular brand name of media because it is like international brand, but we are seeing, particularly when we are allowing them in that particular media, embryos are reaching very soon, madam. Blastocyst, like day 4 itself, it reaching to
Are
blastocyst
you
actually.
talking about single step?
Yeah, single step, madam.
Okay.
So we are, of course, we are all agree that the single step is media is nicely designed. It's like a good to system actually, but
So
the
what do
reaching
you
early
use?
blast.
What do you use?
We have two kind of media we are using, madam. Actually, two media, one Sage and one Vitromed actually, but one particular brand, because I don't want to mention the brand. If you want, I will mention still. Actually, I'm okay to mention.
Right.
But reaching early blast, even the day 4 morning, early morning of day 4,
Right.
I feel personally it's not good
All right.
actually.
I guess we should
Not
be
good.
careful. Maybe you can share that with the embryologists and interested audience, not
Yeah,
whether to use
if
or not.
doctor can share us what is the
Yes.
prognosis of the case end of the day, what is the implantation rate with those early blastocysts on day 4?
Madam, implantation is equally good as we are when we compare to other media, other brand, they're equally good. But the miscarriages and
Then,
those things.
in addition to the question that Dr. Suhasini just asked, have you done PGT on these? Have you checked for euploidy by any chance?
No, madam.
Okay.
No. But we are seeing in our groups actually they are complaining that particular media they are posting that many miscarriages are happening actually.
Right.
So I'm worrying about, because that these might be the reason for one of the reason maybe actually.
Got it.
Sir,
there is another. Sorry.
Yeah, sir, is this happening? I just had one question, ma'am, if I'm
Sure.
allowed. Yeah. Is it happening with multiple patients, like with severe etiologies, multiple etiologies, or severe, like particular male factor or advanced maternal age or something? Or is it across?
In the first growth?
Yes, sir. Like what you're seeing, the early.
No, more or less all the patient, all the profile of patient actually, not
Okay, sir.
particularly actually.
Okay,
But we
sir.
are seeing in particular brand, that one brand alone we are seeing actually. Not I'm saying comparing to other brand, actually that particular one brand alone, we are seeing very fastest blastocysts on day 4 morning itself actually it's reaching actually.
Thank you,
So
sir.
sometimes nowadays we are worrying actually whether to freeze and transfer or not. Of course, there is
Right.
no other way, so still we are doing it actually.
Right. So, got it. I think we should share this with each other on a side note. But very quickly, single culture or group culture? How many for single culture? What is your opinion, Dr. Suhasini?
Single culture will always go with the drop culture.
Yes, but would you
have
prefer
to-
that over group culture?
I mean, I used to practice single culture, and now I'm all doing group culture. I don't see any difference in terms of embryogenesis or in terms of blastulation rate.
Right, Dr. Danya.
It's only you are comfortable.
Sorry, sure.
I think Suhasini, I was just going, I thought I'll just keep the question later, but I think because she's doing group culture and probably because it's large volume, she's not doing a day 3 change. But I go for droplet culture on single in droplet culture. In droplet culture, especially for dry incubator, I feel you should do a day 3 media change, even if it's a single step.
All
Yeah.
right.
So
Devin, what are you doing currently? I'm sorry.
Single in drop culture.
All right.
But it's in the dry incubator. So we have to change on day 3, provide fresh.
All right.
But I think that's doing culture.
Sure.
So that's why she's doing an extended culture till day 5.
Got it. Dr. Devin?
Yeah.
Or
currently I am preferring group culture. On day 3 we regroup good quality embryos and poor quality, and again on day 5 also I do that.
That's
So,
interesting. That's very
regrouping.
interesting.
Yeah.
What do
So
you
I
mean by
group good
regrouping?
quality.
Do you put them in another other dish?
Yeah, we change to new dish, and in that, like the good quality will be in first drop, then the slow growing or B or C grade will be in second drop, like that. So the person who is freezing also, he or she will be like having the good preference that what to be frozen, because they will be checking on the.
You're separating them and culturing them in different dishes, is it?
No. Just for example, like today I have done ICSI and put it in one dish. On day 3, after first check, on
Right.
day 3. Then again we will see, like in first drop there are 281 and 271. So only 281 will be shifted to the first drop of the next dish,
Got it.
and 71 will go to the second drop, like that.
Got it.
Like 41 will go to the fourth drop.
All right.
Yeah.
All right. Yeah. That's what
Regrouping.
studies say. You know, individual cultures decreased blastocyst formation rate compared to group culture, but there is no difference in pregnancy outcomes. So what's happening? Why are our blastocysts not coming? Maybe the media lot changed. Maybe the incubator oxygen was not truly at what it was set out to be. Disc preparation maybe is not equilibrated properly. Drop size or oil, those could be the problems as well. But then we all go back to the basics, to the foundation of it all. Review the patient cohort, age, AMH, and other things. It could be the patient, and the answer may not lie in the lab always. The next question, poor oocyte survival after warming. And these are probably our initial day struggles when we started to freeze oocytes. It was new, but it's worth a mention. It's starting to freeze and the survival is not good. What is it that you will look at in terms of survival rate? Dr. Fairy, would you like to take that?
Yes, ma'am, definitely.
So it has the survival rates are somewhere from, sorry.
So, ma'am, definitely when we talk about survival rate of oocytes, particularly, we know they're so very fragile, and definitely temperature fluctuation. So, definitely, whenever oocyte thawing is into question, there should be skillful person who is handling that, and no other person should be doing that. Secondly, also very strict adherence to the the protocol, the thawing protocol is to be followed. Whatever kits you are using or whatever protocol is to be followed according to the kit mandatory and not your own practice. Like sometimes we, shift the media also. So that is to be taken care of. Other things is like the oxidative stress happens very, very quickly. The osmotic imbalances happens very quickly that we have to take care of. The media temperatures, the shifting of the gametes from one media to the other. These are the simple techniques that a qualified and a skillful person that needs to take care of. So this is what is needed to taken care of, ma'am.
Right. Dr. Shashi, would you like to contribute? Why do
Yes,
you think
madam. Actually,
pigs are not surviving? It is usually 85 to 90%, and suddenly they have dropped to around 60%. What is it that you will first look at?
madam, actually, maybe it could be one of the reason of the oocyte quality, madam. Actually, if there is no integrity while freezing, I mean, if while injecting, if there is no cone shape, we call like there is no integrity, poor integrity.
Right.
Such oocytes, it won't survive actually.
Very rightly put. And it is not always the lab, not always the
Can I
embryologist.
contribute a point here? Whenever we see poor survival of oocyte vitrification, our first thought is who has done the thawing or who has done the freezing, because oocytes are very, very vulnerable for damage.
Correct.
And its embryo is robust. If you miss a second or few seconds, that doesn't matter. But when you come to embryo oocyte vitrification, each second matters.
Yes.
Because the oocyte is filled with the water, there is a high chance of osmotic shock. The water comes out during the vitrification, and water influx into the oocyte during the thawing should be like very precise. The technicality is the key here in oocyte vitrification. Second thought, we will think about the source of the gamete, maternal age, and if any abnormalities are there in the patient, then that all comes into the next phase. But first we look into the person who is actually handling the oocyte vitrification.
So true. You have covered all between all of you, but the most important fact that I wanted to bring it to the notice of all the clinicians that are also involved in this in the audience is that it's not always the lab or the factors affecting that are at play in the lab. It's more often than not than the patient factor itself. If you look at this study, and if you have standardized your freezing protocol, the operator has had his learning curve and he's got there, you don't release
anybody, any embryologist to do oocyte freezing until they've done a certain number, and they have standardized their freezing technique and skill, then it's more often the egg quality of the patient than any other factor. So this paper says it very well, and I wanted to very quickly summarize it, that it's probably the media itself, the preparation, definitely the vitrification operator, did they change, as you have mentioned, did they do it properly, did they perform it properly, as Dr. Fairy said, did the cryo storage is it working properly, is it checked properly, is the QC being done, did we miss anything in the topping it up and things like that. Warming media, of course, and of course I will not talk about the loading technique. I have mentioned it though, because we will not release an embryologist to work with patients' oocytes until we have cleared them, having reached their bare minimum number. Would you agree with me, Dr. Shashi?
Yeah, of course, madam. Yes.
So very quickly, the next question: sperm DNA fragmentation impacting oocyte quality. So this is something that we don't do it very often, but I would like to ask my panelists if they are doing this and they're consistently, your embryos are failing to develop across day 3 in both cycles in a particular case. Suppose that's the scenario. Semen analysis is normal. What is your next diagnostic step, and what is your experience dealing with DFI? Dr. Deven, can we begin with you?
Yes, so actually we also don't do in all the cases. Only previous fertilization failure or previous highly fragmented embryos are there, and with the history of poor quality of semen, so maybe OTA or such kind of patients, and then we recommend that, okay, before starting next cycle, let us do DFI. So
But
again,
in
not
your
in
experience, did you see that eventually when you, after a failed cycle or failed embryos, poor grade embryos, and DFI was done, you could correlate the poor results to the DFI? Did you see that?
Yes, so in majority cases we were able to. Yes, there were few cases where we were not able to correlate, but yes, in majority cases there was DNA fragmentation high.
Okay.
And then we chose microfluidics and all that, or maybe we give some rest.
But you won't do this as a blanket policy, isn't
No,
it?
no, 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 no.
For everybody.
Nobody is doing
Right.
that.
Dr. Fairy, do you do it?
No.
As a policy? Anybody here does it as a policy, DNA fragmentation before they take on IVF?
No, ma'am.
Nobody does.
We usually follow certain criteria to identify the indicated patients to go ahead with the DNA fragmentation test. One is if the patient has normal semen analysis plus they have varicocele, or if they have any addictions, long-term addictions like smoking or drinking or any other recreation drugs, and if they are high diabetic profile, and
Right.
we take these patients as indicated patients to go ahead with the DFI test before going for the first cycle itself.
Wonderful.
And secondly, if everything is normal, but the first cycle is unfortunately no embryos drawn, then these are all the potent indicators for DNA fragmentation analysis before going for the second cycle.
Right. And what is your method of DFI examination?
We do SCD method usually in the laboratory, and
Right.
if it is needed, sometimes we go for flow cytometry as well.
All right. So, Dr. Danya, would you like to contribute anything? What is your experience with DFI and embryo quality?
Yeah, DFI, we also don't do it on a regular basis, as Madam pointed out. For smoking patients, clinician actually asks for DFI, and in our when we have an attempt with fragmented embryos, that is where we ask, or if there is failed attempts, then we look into DFI.
Right. It's unfortunate that DFI is an expensive procedure, but many times we can't do it because it's unaffordable for patients. So, however, if we look at studies, definitely a threshold of more than 30% is associated with not just poor pregnancy results, but also embryo chromosomal abnormalities. as papers have already elucidated. And it's not just about the method that we are using. DNA fragmentation, when preserved and good sensitivity is achieved with tests, then it has definitely shown to be affecting pregnancy outcomes. So, which is the test that we are using is very critical. Of course, it has to be standardized. Is it tunnel, SCSA, or SCD? Is the threshold being applied for the test that is used? That's very critical, because some reports are very skeptical. Has TISA been discussed with the clinician and the patient, as the next step before microfluidics or anything is advised? Because there is conflicting data between testicular sperms and microfluidics. And is oxidative stress in sperm preparation media also being very carefully looked at? Not just the media, the method as well. Very quickly, the next question.
I quickly wanted to share one point here.
Sure.
So of late, what we are doing is we are encouraging male patient to have very frequent ejaculation throughout the stimulation period, women's stimulation period, like in at least once in 2 days, or once in 3 days. So by the time they come for the ICSI procedure, we wanted to have as fresh as possible sample, and wherever it is possible, we are taking the second sample for the ICSI procedure.
Right.
I mean, we are seeing a wonderful change in the blastulation rate in this method, particularly with the patient who are like a borderline DFI. Like, we don't want to go for patients who have 30% or 35% DFI directly to the testicular sperm.
Okay.
Who are like 20 to 30 in between. They're like in between. We wanted to we don't have time to manage them with antioxidant as well. We have to take care of women. So in this kind of patients, we are doing multiple ejaculations and then using the second sample for the procedure. And if possible, we are also employing microfluidics with this. With this, we are
on the same day, you're saying?
Yes. On the same day with 30 minutes difference, we are taking second sample.
Got it. A number of people have proclaimed this in many conferences.
Yeah. We are also doing with severe OTA cases 2 collections compulsory and
Correct.
using second sample.
Right. Right. So, thank you. I'm moving on to the next case, abnormal fertilization. You walk into the lab. This patient has had previous 2 failures, and you come in and see that it is presenting itself, the egg or the zygote, with a single PN. What do you do? Do you want to culture it? What is your lab policy? What do you think the evidence is? Will you transfer it if you have embryos? Dr. Dhanya, would you like to take it?
Single PN, I would culture it to D5 and then take a call. And that will be if there are other normal PNs, normal 2 PNs, whatever embryo is derived from that will be my first preference, and this I would put it towards.
Right. Dr. Ferry, how about you? What do you do in your lab?
Ma'am, usually, if it is like a single PN, we'll go with the culturing, definitely. And if it's a 3 PN, we'll see it's a multinucleation. So whether we'll review the ICSI technique for sure, and evidence-based protocol we'll be following. And also we'll be assessing the fertilization timing as well. We'll check.
Right. But
what
will you let, these are 2 things that are separate. If it's a 1 PN, would you like to culture and transfer?
Yes,
If
ma'am.
it's a
I
3 PN,
would see how the formation, how the cleavage pattern is, what the formation is, whether day 3, day 5, how the embryo goes with its pattern.
Right. If it's a 3 PN, would you like to culture and transfer?
No, ma'am. I would not prefer doing that.
Would you be separating them on the fertilization check day itself?
Yeah. I would separate it, ma'am. Definitely. Because there could be some abnormalities, meiotic division abnormalities, definitely. So I would definitely go with separating it.
Right. Dr. Shashi, do you agree with us?
Sorry?
Do you agree with this?
You mean separating them and allowing, right?
With the whole protocol of culturing 1 PNs and, considering transferring them, and 3 PNs separating them right on the day of FERT check.
Regarding the 1 PN, madam, actually, if we try to check the FERT check on right time, then there could be chances for missing of micro PN actually. Because when we are working with time lapse, many times actually we are seeing we were seen actually there's micro PN actually along with the big PN. So after checking right time the PN, if still there is a 1 PN, then of course we can allow them, and we can of course usually we do not transfer them actually. Even
Right.
reaching also we don't use them because it is our protocol we are following. And
Right.
regarding PN, recently we got one case, one patient, 3 PN actually. Many of the embryos reach because of the cytoplasm poor actually.
Okay.
So while we faced actually some difficult, and there was no cone shape, no integrity failure. So this reason actually the second polar body not released actually. So it appeared as a PN actually.
Something.
So,
Well, the paper on your screen, it's a wonderful paper. Look at the number of embryos, and they have shown that it's better not to discard, especially when you are dealing with very few oocytes, one or two, and you'll end up with one embryo. Might as well take it to blastocyst and transfer it. It has a low success rate, reduced rates, but it can definitely be transferred, especially in those conditions. Of course, about euploidy and when they looked at the euploidy as well, they have seen that healthy babies can also be formed from 1 PN. But the issue comes, this is how it can be dealt. A lot of things like Dr. Shashi was saying, denudation, timing, late denudation, fertilization check. Dr. Ferry, you pointed out, the protocol also has to be looked at. IVF versus ICSI, extended culture to blastocyst, that's a very important thing. Take it to blast. If it's culturing and growing very well, then probably consider transfer, and document everything so that we can observe what happens the next time if they ever come, the patient. But the problem comes with 3 PN, isn't it? This is the issue where definitely there could be a compromised chromosomal competence, which is why many papers say that it's better to discard them and not transfer at all.
and there is a small one experience we had it actually. Very long back, we got 3 PN, then we were trying to remove the 1 PN actually, madam. But finally we failed. We removed, of course, but followed by the oocyte was degenerated.
That's very interesting, but very sad, isn't it? I don't think it's done on a regular basis. So,
Yes,
was the insemination correctly done? Was the timing appropriate? Everything has to be reviewed clinically, definitely. But most of it comes from how the ICSI is performed. So, I think we should be very careful because over the past 20-25 years, training so many juniors, I have observed that when they do this blunder, this mistake of transferring more sperms knowingly, unknowingly, 3 PMs are formed. Especially when you have few eggs, you have to treat them like diamonds. So that's very critical. The last case, difficult oocyte morphology. Now, these are decisions that you need to take. Do you go talk to your doctors immediately? Do you do it after embryos are formed? Because many clinicians, I've worked with many because I used to travel a lot with Apollo and various other companies that I worked with, that your embryologist comes running, and even as soon as they've done the ICSI, they want to say that the egg quality is not good, so that tomorrow if the embryo is not good, they can very quickly say that it was because of the egg quality. But do you discuss them separately? Like, SCR was there, smooth endoplasmic reticulum, vacuoles were there. Do you define them particularly so that your clinician can also understand how to counsel patients? Dr. Suhasini, would you like to take that?
Yes, we certainly have this dysmorphism percentages. We see what is the prominent defect that oocyte carry and what is the prognosis of the case. We discuss with the clinician, like, what is the that particular dysmorphism that is happening in this patient oocytes. As you mentioned, SCR has its own drawbacks. And we have this prescribed traffic light system by Eshrey and Istanbul Consensus. If the recent consensus says if SCR is there, do not touch the SCR, inject it safely. They also mentioned that healthy babies are born out of this SCR present oocytes. So we make a note of all these dysmorphisms in the patient file, and we'll discuss with the patient. and we will give the prognosis of the case. So these are all the percentage of dysmorphism that is happening in this case. These many oocytes have this kind of dysmorphism. So this is the prognosis of the case, good, bad, or average. Based on that, we'll treat. Plus, we also treat the, separate the oocytes that have more than 2 or 3 dysmorphisms. Say like SERs. SERs, we always culture separately. We don't club them with the regular oocytes.
Okay.
That goes like a last preference, because it is also said that SER present oocytes have a kind of genetical abnormalities. So we give least preference to the embryos that have arrived from the SER present oocytes.
Right.
So if it is like a cytoplasmic
Would you
vacuum,
say in your list it ranks the the topmost when you want to reject that embryo?
yes. I give most preference to SER aggregates.
Would you agree, Dr. Deven? Would everybody agree
Yes.
SER is on top?
Yes. SCR on the top.
Tanya?
Absolutely. Yes.
Dr. Ferry, Shashi, everybody agrees, right?
Yes, absolutely.
But still
And
we use it
rest
for the
all-
freezing, madam.
Of course.
Yeah.
Sorry,
There is no other embryos for the freezing, but in such a cases there is no,
Yes,
no
but,
choice.
but isn't that what we do? We prefer it at the end. We don't want to freeze it in the first cryotop or
Yeah.
prefer it in the beginning.
Only
Dr.
blastocysts, no
anything
day
else
3.
you want to add?
So if it is like any other abnormalities apart from these SERs, like vacuoles or the dark cytoplasm or refractile bodies or any abnormal zona or enlarged polar, these are all contributes to poor embryogenesis. So it is very evident, we can see the poor conversion, but only with the SER we have problem with the genetic abnormalities.
Yes. Well,
I see
sorry, Dr. Anya.
No, I get worried when I see heavy debris in PVS. I feel that those embryos which are generated from that heavy debris in PVS, sometimes they don't move forward. They have compromised developmental. So when I see heavy debris in PVS, that is a little alarming. That I inform the clinician also that the oocytes were.
Right. Very rightly put.
I completely agree, madam. Actually, there is debris in the perivital space. There recently there are 20-30% of cases we are seeing in our clinic. Embryos are not reaching to blastocysts actually.
Okay.
It arresting on day 3 or day 4 because of the debris.
Yeah.
We know really don't reach to blast, but still there is no other way for us actually. We have to allow them.
Even I feel there is reduced blastation with
Sorry?
everything.
Also,
No,
ma'am,
even
I've seen.
I've noticed.
Yeah, also, ma'am, I've seen like poor conversions, not with all, but yes, in few of the cases with fragmented polar bodies and also the flat polar bodies, like the M1 conversion to M2s. That
Right.
scenario is seen.
It's very interesting to see what demon we are all carrying on our backs, because this comes from so many injections that we did, so many tremors that we have when we are looking at these particular features. In the interest of time, I could not put the data about each specific dysmorphism. There is data available about zona pellucida, vacuoles, SCR, perivateline space. Everything is available. So it's very interesting that we backpack our experience and come on. Each one is critical, each one is important, and it's good to learn from each other. So definitely the oocyte dysmorphism contributes to the embryo quality, and it does affect not just the fertilization, eventually the blastocyst outcome and pregnancy outcomes as well. As Dr. Suhasini said, topping on the list is SER. We all could not agree lesser on this. Of course, we don't discard them when we don't have anything left. We do transfer them. However, as she said, it's last on the list, last on the cryotop, last on, and done with proper counseling to the patient as well. Would you all agree with me?
Yes.
Yes.
Right, because many can't afford to go for PGT of these SCR embryos. Therefore, proper counseling of what we are doing with the patient so that she can follow up with the right fetal medicine department so that they can track her properly. I guess I'm done. Thank you very much, my panelists, my audience as well. Thank you, Kalpana.
Thank you.
Thank
It
you
was
very
great.
much.
Thank you, Kalpana. Kalpana ma'am is not there. Ma'am? Hello. Okay, if it's just us, thank you. It was such an opportunity to meet all of you, my embryologists. I'm sure ma'am is there. Just give me a minute, everyone. Hello, madam. Hello. Ma'am, I'm Suarchila, ma'am, Hyderabad panel. We just finished, ma'am. I'm sorry, everyone. I think she. We'll wait for a couple.